Welcome everyone to today's program. I am Carrie Pallardy with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You'll receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You'll also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Since 2003, Lisa Rock has served as president of National Medical Billing Services, one of the largest ASC billing companies in the country. Lisa is a seasoned healthcare management veteran with over 25 years of experience in the industry. Her wide-ranging background consists of positions such as Director of Training and Education for the largest regional payer in the Mid-Atlantic area for 7 years, and Vice President of Business Office Operations for an ASC development and management company for 2 years. She has also managed private practices in the specialties of orthopedics, retina surgery, cardiology, and anesthesia. Early in her career, Lisa worked in the OR and PACU in Northern Virginia. Her unique knowledge of healthcare management provides National Medical's clients with the tools and information they need to most effectively run their facilities amidst the highly fluctuating business of medical billing and compliance. Scott Allen joined National Medical Billing Services in 2008 and is the Vice President of Managed Care Contracting. He manages all aspects of ASC managed care contracts, which include analysis of language and rates, contract audits, and developing best practices for implementing standard operating procedures for the managed care contracts throughout the revenue cycle. Scott is heavily involved in the ASC industry through a variety of advocacy roles. He serves on the Payer Relations Committee of the Healthcare Billing Management Association and has lobbied on Capitol Hill for the Ambulatory Surgery Center Association. Scott is also a frequent contributor to industry publications, writing about managed care contracting and other ASC topics. Scott earned a BS in political science from St. Louis University. It is now my pleasure to turn the floor over to Lisa Rock to begin today's presentation.
Thank you, Carrie. Let's go ahead and start on slide 2. Chargemaster review. We're going to discuss the multiple ways that chargemasters are being created and managed. We're going to discuss how payers define certain items in a contract with respect to surgery center coding and billing. We're going to discuss how this impacts the revenue cycle in terms of claim submission and reimbursement. And we're going to give you some detailed inside information in managed care contracting as it relates to the revenue cycle. On slide 3, let's talk about setting a chargemaster first. In order to properly set a chargemaster, we want to understand how our current charges are being reimbursed. So we're going to not do the typical thing and lay out in the spreadsheet by CPT code and your allowed amount by payer, but instead we're going to group the CPT codes by case and look at your case rate allowed amount. And so you're going to take a group of CPT codes, for example, ENT might have 5 or 6 codes, and then you're going to layer the contract on top of that, do your top 10 cases first, start there, and find where your reimbursement falls or your allowed amount falls with the case rate and not a by CPT code rate. It's the biggest mistake that we see in analyzing current charges. So now we're ready to set our chargemaster. We know that perhaps some of our charges fall below allowed amounts in terms of the case. So we're going to want to increase our chargemaster. And there are limitations on increasing your chargemaster, which I'll talk about in a second. But let's talk about how we're going to set a chargemaster. So there are multiple ways right now. You can use a multiple of Medicare, which has sort of been the case for the majority of surgery centers in this market for the last 20 years. using a multiple of Medicare works most of the time, and where you don't have a Medicare crosswalk, then you would come up with a different methodology for that particular case or code. You can also use Fair Health. Fairhealth.org has some good information for surgery centers, and you can get an idea of your particular area by going onto their website and understanding that most of the data there is HOPD, but still, if you're working in the 50th, 60th, 70th percentile, you'll probably be, for the majority of cases, in line with where you should be setting your charges. The other option is to use state-collected data to come up with your Chargemaster. And it's very common to use a combination of these three. So from a coding and billing perspective, when you're appealing, it is a little more difficult to appeal to a carrier for additional reimbursement if you're out of network, for example, if you're using Medicare as a benchmark, because they will too when they adjudicate your claim. That's a separate discussion, but it's good to have a solid methodology for calculating your Chargemaster. So now we've calculated the Chargemaster, and we're going to apply our cases again. And we want to make sure that we take cost into consideration too, because some of your contracts are not going to cover very expensive implants or multiple procedures, and so we need to understand what the cost of doing those procedures would be before we set the price. Now, once you've analyzed your contract, if you find that you're falling below an allowed amount and you need to adjust, you have to read all of your contracts to make sure there are no limitations. One contract can limit your ability to increase your Chargemaster across the board. And so the payer may require notification. They may have a certain time period for you to notify of a Chargemaster increase. And if we go to slide 4, we're going to talk about something else that we're seeing in your Chargemaster increases. So let's say you analyzed, you have a methodology in mind, and now you want to increase. This is an example of a contract with language that states that you are allowed to increase your Chargemaster no more than 0%. In addition, if you look further in this little paragraph, you'll see that we can't fragment. And what that means is, what we've done for many, many years in this space is, if we have limitations on increasing our Chargemaster, well, we will simply do a revenue neutral increase. We'll increase on more frequently performed procedures, and we'll decrease others that we really don't see high volume on. And therefore, if we have a percent of billed in our contract, which a lot of you still do, then this is an increase automatically. Well, this language states that you can't do that. You can't line item increase. So any line item increase would have penalties. If we go to slide 5, this is an example of language in a contract, today's contract, that shows the penalty, which is ambiguous, interestingly enough. We're going to look at a contract that has a 40% discount off of billed charges. And if we adjust our Chargemaster more than the allowed 5%, then the carrier is going to take an additional discount. In this case, it's a revised discount of 43%. And the language in this contract states that the carrier will apply this similar methodology as a penalty. And again, ambiguous language, but it's there. Scott, did you want to add anything to this?
You know, I just want to point out, I think that, you know, we're seeing a lot of providers not taking advantage of these Chargemaster increases. You may be allowed 5% annually, and you haven't increased your Chargemaster for 3 or 4 years. So make sure you understand the contract. You may be able to compound that and you know, stack up those annual increases and then do one lump sum for, say, 15 or 20%.
So I think that's a really good point. If you are allowed a 5% increase and the other contracts do not prohibit you from that 5% increase, and you haven't taken advantage of the 5% increase, say, in 4 or 5 years, if the contract does not specifically state that you are not allowed to stack, then you can stack those increases. So whether you want to do it or not is up to you, but you do have the opportunity. Any improvement in your contract, right, goes straight to the bottom line. Correct. Without changing anything. So we would advise taking a look at this, a contract that's already in place, and if you have a percent of billed reimbursement methodology, and again, a lot of you do, then again, this increase will go straight to the bottom line. All right. On slide 6, carriers will put in the contract or in their online provider manual specific language on what they consider to be a clean claim. And what's interesting about this is for those payers that fall under HIPAA, we're using standardized transactions and code sets. But for carriers that are exempt from HIPAA, you may be required to bill with homegrown codes or something that's out of the norm, and it may not be specifically defined in clean claim language if there is clean claim language there. But you definitely want to read this piece because the carriers will specifically tell you if they consider a 1500 a clean claim or a UB form a clean claim.
Or both. And that's a good story we have there would be a large payer actually per contract stated you could bill with either the UB or HICFA, and what they were doing was denying per claim form type. Mm-hmm. And so I think it's important to make sure that you clarify that within your contract.
Well, in addition, let's say your carrier in the contract requires you as a facility to use a UB form, and your claim is loaded in the system as 1500. Your claim will still get paid probably, but most likely be reduced to a professional reimbursement. And so starting at the very beginning and reading your clean claim language, whether it's in the contract or in the provider manual, which the contract will follow, then you need to check and make sure that your software system is properly set up for the correct claim form. All right, slide 7. And we talked about the 1500 versus the UB. But interestingly, we're seeing this a lot. Look at, I think there's a third sentence down. Claims may be subject to standard claims editing software to detect bundling and unbundling. All right. As far as I know, there's only one national edit system, and that's the National Correct Coding Initiative. There is McKesson's product Claim Check, which is utilized by the Blues, most of the Blues. Most of your major payers are going to use one of those. Primarily, we see the National Correct Coding Initiatives being used. But if you allow language like this in your ASC contract, you are now subject to whatever bundling edits the carrier deems are appropriate. So if they feel, the carrier feels that procedure B is inclusive to procedure A, but it is not considered bundled by CCI or McKesson, you're kind of stuck. You have no recourse because you allowed very vague language to dictate what's payable and what's not. And believe me when I tell you, that little line in there is used often to deny claims.
Yeah, we're actually seeing a lot of this with the pricing companies, large pricing companies, initials, MP. They actually have language within the contract now that allows them to edit and bundle per Medicare. So if your current contract pays percentage of billed charges, let's say 80% of billed charges, and you've been receiving those payments, their education system has just recently allowed them to start taking the MSR discounts. So check your contracts, section 5.2B. It may be a different section, but it's definitely in there.
So that's interesting. And across the board, something to note. If your contract is a percent of billed, and you're used to getting a percent of billed, know that now payers are beginning to enforce or add language to contracts that allow for multiple procedure discounts in a percent of billed environment. So if you're negotiating a contract and you're still able to get percent of billed, and in some areas you are, depending on the competition in the market, then I would recommend that you address the multiple procedure logic in percent of billed.
Yep.
Also, something else that we want to mention on this slide is that carriers will dictate to which revenue code you're to use, which modifiers you're to use, and again, some homegrown codes, those that are exempt from the standardized transactions and code sets. And you might think you're supposed to be using a modifier because that's what the rest of the world uses, or a particular revenue code for implants. Mm-hmm. And that one little change, if you read this contract, will make all the difference in the world.
Yeah, I think one more thing here to point out, this last line, Lisa touched on this earlier, would be, contracts do state you'll be paid lesser of the two, the bill charge or the rate per contract. So it's so important to make sure you have complete copies of your contracts and understand them very thoroughly.
Well, that takes us to slide 8. So having complete contracts is critical for you to do business. And you have to read every part of it. You're going to have to understand product participation. So what am I signing? Am I signing the HMO, the PPO, the Medicaid replacement plan, the Medicare replacement plan, workers' comp? We're even seeing motor vehicle insurance is coming, a contract coming along. And so you have to understand what those different products are, because the carrier is receiving a higher premium dollar for the richer plans. And so you want to make sure that if the carrier is receiving a higher premium dollar, that that's passed down to you as an ASC. So for example, I would have a fee schedule for my PPO, I would have another one for my Medicare replacement plan, and I would have another one for workers' comp, whatever. And so understand what each product is. And if you're getting one lump sum for all of the products, I would say the carrier probably has a really good deal.
Yeah, and the work comp area is one we see a lot. The payer taking advantage of providers. And what will happen is we'll give you a contract, and
well, you know what? We've got this. Let's go to slide 9. And go ahead with your slide.
So they'll send a contract over. It'll have multiple products, and it'll be a large commercial payer, but they'll have a work comp product in there, and they'll say, per this slide, they'll say, we'll pay you 90% of the state allowed fee schedule. And the problem with that is you're not receiving any direction of care. The payer is only taking that and selling it as a discount. So those are pretty easy to get taken out, but like I said, you have to understand it and fight it.
Understand what you're looking at, right?
Yeah.
So okay, So we see this not just in workers' comp, not just in that product, but we see discounts in Medicare.
Medicare Advantage products.
So where are you going to, you might say, well, you know what, I'm getting Medicare rates, so it's a give and take. Well, if your contract is 150/25, you're no longer at Medicare rates, you're below Medicare. So you have to do all of that math prior to signing the contract so you understand that whatever rates you have for Medicare or Medicaid replacement plan actually mirror what you would get straight from those payers. Oh, by the way, this is a 10% discount, this example that we have here on slide 9, but we have seen as high as a 30% discount off the state fee schedule. And it's something that you have to be aware of.
Yeah, in some states that don't have work comp fee schedules in place, actually the payer will try to use a Medicare methodology or grouping methodology to reduce your rate even further. So states like Wisconsin, they don't have a set rate for work comp.
Okay. Now, on slide 10, this is important for out-of-network surgery centers. In the professional contract, the surgeon's contract, the surgeon may be required to notify through prior authorization the payer when he or she will be taking a case to an out-of-network facility. And if your operation is one that the professional side obtains the pre-authorization for the professional and the facility, the carrier may not tell you that the facility is out of network and therefore requires an authorization, because that procedure in network doesn't. And so with carriers now getting very tight on retroactive authorizations, it is critical that your staff understands out-of-network procedures many times require auths where in-network do not. So if you have that situation with a pro referring to an out-of-network and the pro is doing the due diligence for both auths, then you're going to have a problem. Just to make sure people.
Yeah, I think this is really important. The front end right now is so huge to make sure we get everything in place and make sure you're accurately taking down the insurance type. You identify what plans are going to be exchange plans, and you arm your front desk with these contracts so they know what things are going to pay beforehand.
Well, I mean, that's a really good point. The exchange products are identified usually by some kind of a metal, gold, silver, or bronze. And then the other way that carriers identify the exchange products for you is on their member ID card. There are specific prefixes typically that go on the cards. Again, understanding what those prefixes are by payer. You know what would really help too? You can go on state websites and get a list of the payers participating in the exchange products. And then you can educate your front desk on how this works with exchange products, because you may have a different rate for exchange products in your contract.
Yeah, and some of the large commercial payers actually let you go online to websites and extract that information or email your provider rep.
So that was a little side thought. If we go to slide 11, we have a number of issues that can affect contracts. Coordination of benefits, one. You have to check with state laws on this particular issue. So, for example, if a guy who drives a dry cleaning truck is delivering a product and someone hits him, but we find out he was driving drunk, well, we have an issue of who's responsible for paying the claim. And your state law will have specific subrogation information for you on who's responsible for paying, whether you have to wait or typically what we see is a pay and chase. So if you're under contract, then the private payer would pay and then wait to see who's responsible and then notify you, and then that's when the recoupment or offset would begin, but typically the private payer would have to notify you of who that is. and then you will have a certain period of time to refund that, which is not a lot.
And that's a good point. I think is some payers don't allow you any recourse. We have contracts that states, they can just start recouping money right away without any type of formal letter or anything. So it's important to know that section in your contract, read it, understand it, because it's going to apply to adjustments, recoupments, offsets going forward.
Right. Most of the time, I'm going to be honest with you, most of the time I see recoupments of any kind, other than coordination of benefits, they're getting a fight.
And I think this is why you have to arm your payment posters with the correct contract. They got to post per contract, because what's happening is they'll just put this on the EOB, start retracting money, and you don't know it if you're just posting per EOB. So.
Interesting that timely filing should be at a minimum 6 months. We continue to see contracts with timely filing of 30 days. Now, with motor vehicle accidents, there are several states that have timely filing for motor vehicle insurance. So your Geico's, and that should be listed primary in your billing system. You get a letter of exhaustion, and then you send it to the private after that, which should be listed second in your billing system. But many states have a 30-day timely filing limit on those benefits. So that's not anything you can override in a contract.
You can't work with state law, but I think with commercial contracts, pertains timely filing, and also claim submission, it's pretty easy to get that moved up or down, whatever you need to do.
So on slide 12, we were talking about timely filing. And what you want to be careful of is that if your state allows a certain period of time, you want to make sure that your contract doesn't shorten that time.
Yeah, and contracts will also state how they want you to submit the claims. Do they want to do a percentage like electronic? Do they want to do all electronic? Mail. We have some instances where we have trailer billing. So there's all kinds of different.
Okay, trailer billing. For those of you that don't know what that is, it is when the carrier requires you to submit the facility fee by itself, pay, and then you take that EOB, submit another claim form with the implant, if applicable, and that goes in separately. It's bizarre, I know, but some contracts have trailer billing, so if you have denials on your implants, unlikely this is the problem, yeah, but it could be. It's not typical. One more reason you have to.
Feel free to send any questions over. That usually happens on the East Coast.
Okay. We're going to skip to slide 14. And if you look at the first paragraph, and I think it's the third sentence, payer may change its payment policies from time to time. And in the event that the payer changes a payment policy, the payer will make available the information describing the change. That doesn't necessarily mean they're going to tell you. It means that it's probably going to be loaded in the provider manual. And none of us have time to comb through changes in provider manuals on a regular basis, but understand that the carriers do have the power to change your payment policies. And that can mean anything, but it typically means medical necessity and changing a required diagnosis in order to support medical necessity for a reimbursement. And you have to really watch this one, because if you notice a change, and again, the person that's going to notice this change is your payment poster. They're going to see it firsthand on the EOB, so they have to understand the contract. And we're not suggesting that you arm your entire billing staff with contracts, but someone has to go through and read this word for word who understands revenue cycle and contracts, and come up with a matrices to, or cheat sheets for the entire billing staff to follow so that they can discover changes like these, which are really hard to discover, by the way. I'm challenged too with it. And I've been doing this, unfortunately, more than 25 years, 35 years I've been doing this, and it's still very difficult to stay on top of all of these changes. Nevertheless, if you are seeing a reimbursement change, either a reduction or a denial, and you don't typically see that, you have to figure out why, and that is to go, and you need to go on the payer website and find out what it is. But again, it's usually a medical necessity change. Could be an auth change too. As Carrie mentioned earlier at the beginning, I worked for a carrier, a large one, for a long time, and we would come up with a list of items that require pre-authorization. So a separate list for notification, and notification is very different than authorization. And typically you see those auths on frequently performed procedures. So we would run a frequency report, and top 10, we would start putting auths on. So 20 years ago, that would have been a hysterectomy. 15 years ago or so, it would have been carpal tunnels and so on and so forth. And so you have those auth requirements. And then once you watch the data come in, you make a decision whether you want to continue requiring that to be authed or not. So that list changes every month. It can change every month. So just because something requires an auth today doesn't mean it's going to require one next month. Conversely, right? If it doesn't require one today, it may require one next month. So you really have to call all the time and find out what these changes are prior to the surgery.
And you have to know where it's going to be listed in your contract. And you have to have complete contracts on file. And I'll be honest with you, we do a number of audits all over the country, and I would say, 70% of the time, providers don't have complete copies of contracts, fee schedules. They don't know who the provider reps are.
Or we'll receive just a cheat sheet on the rates. And like I said at the very beginning, that first slide, you cannot look at ASC reimbursement by CPT code. You just can't. Now, if you're an eye surgery center, okay. But if you're an eye surgery center and you want to add another specialty, you're going to have to look at the case. And you're going to have to look at, and again, it's looking at your contracts in a very different way. So you may think that you have 200% of Medicare. You take that contract and how it adjudicates claim, whether it's 2 procedures or 5 procedures and your implants, and you take that performed case and lay it on top of every single contract you have. I think it will be eye-opening for you. Many, many times, we are very surprised to see rates as low as 25 to 30% of Medicare. You can't survive on that. And carriers want to work with you. They want to move business from HOPD to a surgery center. It is more cost effective. It really is. But if you don't know your own numbers, they're not going to hand it to you on a silver platter either. So you have to understand the political environment as well. Is the local hospital a local hospital, or is it one of 135 hospitals? That changes your negotiating power just a little bit. So just understanding all of those pieces while you're negotiating your contracts is critical. All right, on page 15. Same thing. All right, we'll go to page 16 and jump right to page 17. Interestingly, you do have accreditation and licensure language in your contract. Typically you do. And in this case, the example shows that second paragraph, Joint Commission on Accreditation of Healthcare, JCO, and or pretty much anything that falls under Title 18 of the Social Security Act of 1972. So we're okay with whatever accreditation we have here. We have to have one or we don't get paid. I've seen contracts with specific accrediting agencies listed here. So just be careful, because we have seen that, not too often, but we have seen a AAA and they want a JCO, or a JCO and they want a AAA, and it's old language and you can usually fight it and win. Nevertheless, I would make sure that I had something that tailors whatever surgery center, whatever your compliance credentials are. All right, 18. You want to talk about your terms?
Yeah, term structure. I mean, just basically it's pretty basic stuff. Just knowing, how long the initial term is of your contract and if it will auto-renew going forward. I think one of the most common questions I get would be, can I renegotiate during the term? Can I get carve-outs added to my contract? I just signed this last month. And that's a tough question. It's going to depend on a lot of different variables. I think if you have good leverage and you have maybe a new provider, you can maybe get that worked in. But a lot of times these terms are set in place for a reason. So they want to lock you in for a 2 or 3 year term.
And that initial term is almost impossible to get out of.
It's tough.
Now, if I've added a new specialty, all right, I can call the carrier and work with them, and if they're good and they understand that you have a new, let's say you're an eye surgery center and you're bringing on retina. That's a different specialty, and my current contract doesn't accommodate that. They have to work for me or work with me here because I want to bring these cases from hospital to the surgery center.
Yep.
So you make that argument, you should be okay. But if the carrier gets you to sign a 4-year initial term, they're probably pretty happy with the deal, just so you know.
I think other things to look at too would be, having some sort of escalator built into that contract. So if it does renew, you get, 5%, 10% annually increase.
All right, we're going to go to slide 19 because this is the reason why ASC billing and contracting is so difficult. It's different than in a hospital, and it's different than pro or ancillary services billing. And this is why, because our reimbursement methodologies are all over the place. We have groupers, 2004, 2007. A lot of folks that come from the professional side are used to RVRVS, and there's a reason for that, and there's a reason why it was developed back by the Dr. Chow Harvard study all those many years ago, back in the 1980s. I remember when it happened. And ASCs were reimbursed on, it was like 8 groupers back then. And something like a tonsillectomy was ungrouped because the elderly simply didn't have a tonsillectomy, so there was no reason for Medicare to group it. So what carriers started to do is move those ungrouped codes into their own groups, and then they thought, what, we can do this too with the high volume procedures. So I'm going to take this Medicare Group 4 and I'm going to move it to a 3. And so you have to, if you still have grouper contracts, you must crosswalk your groupers to Medicare so you can see where they fall. We have a percentage of billed still in existence, especially with implants, and depending on the part of the country that you're in. We still have ambulatory, well, we still have, because groupers switched over to ambulatory payment categories. I want to say, gosh, now I don't even know, maybe 5 or 10 years ago. I can't remember, but there was a switch over. Oh, yeah, it was 2008.
Yeah, and that's a good point. I mean, we have clients on contracts that, when they come aboard that are 5, 6 years old. I think so. They're on older methodologies.
They're on older methodologies.
Percentage of Medicare is older.
What we're seeing a lot now is a case rate, and just to give you an example, in a hospital environment, what we used to do as a payer when I worked there is, say, cardiovascular surgery. You'd have a CABG, which is a coronary artery bypass graft, very expensive procedure, and we would pay one case rate, and all associated costs with that particular diagnosis group would be paid under that case rate, including the professional fees and anesthesia. So we are seeing that now start in the surgery center environment.
Carve-out, this is one we hear a lot. I think everybody thinks it's a great thing. Who doesn't love a carve-out, right? But I think it's very unassuming because they can actually be bad. You have to understand, what type of carve-out you're going to get and how you build the implant cost. Let's say there's new technology that comes out and you just sign this agreement for a certain rate for a carve-out, and now this new implant costs way more. Or understanding how that carve-out code is going to adjudicate within a claim that has, codes that are not carved out. So we see contracts that will have a carve-out code, but then to perform other CPTs associated with that case, you're only going to be paid for that carve-out rate, and that's it. So just be very mindful of what you're signing when it comes to a carve-out. They do sound great. One more thing I wanted to point out on here too would be any updates to Medicare 2015. So let's say you're doing pain management and your current contract's based off 2012 Medicare. And they want to go to 2015 Medicare. That's not always a good thing because a lot of the codes are going to bundle. And so you really want to make sure you understand the methodology you're currently on and what you're switching over to, what that's going to mean to not just the rate for each code, but then how it's going to actually adjudicate and pay that claim.
We talked about the multiple procedure logic mirroring Medicare, or how it doesn't actually, and how to utilize combination codes when you're evaluating your Chargemaster. Having escalators in your contract to accommodate cost of living, but don't start demanding an escalator. Get your rates and then discuss your escalators. And we discussed leveled reimbursements, and that's really by product and getting that additional reimbursement passed down to you. If we go to slide 20, I'm going to quickly go through the last couple of slides here. We talked about case rate. We're seeing this more and more in the surgery center environment, which would include the professional and the anesthesia fee. Mm-hmm. We are really seeing this. And again, it's something it's not new for payers. They do it with hospitals.
That goes with the next slide here. I think, what 21. We're seeing is payers are coming to us saying, hey, we want to let you do this total joint, but if you do, we want to try to give you this global rate, like Lisa said, that will include the anesthesia and the pro fee as well. So just be on the lookout for that.
On slide 22, this is an example of a percent of billed contract on your implants. So my threshold is $2,000. Setting your Chargemaster, this is a soft charge. You're not going to hard code this in your system, so your coder, your charge poster has to calculate this every single time you post an implant charge. If my threshold is $2,000 and I meet that with my expense, or depending on how your contract's worded, but this is typically expense. If I do what most surgery centers do and double that, $4,000, and my reimbursement is 37%, I've just lost money on my implant. And the contract will also tell me how much I'm allowed to bill now.
Yeah, read the fine print below. They will often state that they want you to bill out at invoice cost. They can come back and audit those invoices, make sure that you'd be liable for that in the back end.
But if they have 34, 35, or 37% of billed, they know exactly what they're doing, and they know that you guys typically double your invoice, and they know you're going to lose money on that.
I had one recently that actually paid at that percentage of bill, and they wanted you to bill at invoice cost. So they knowingly were giving you a pretty hefty discount on your invoice. And
when you hear, wow, I'm not getting anything, 37% sounds great, and I can only bill at invoice cost, that sounds fine. No, that's not good.
It's not good. Yeah.
All right, and then slide 23 is an example of a case rate that is for the surgery center only. And what's interesting about this, go ahead, Scott.
Yeah, it's based off how the codes are grouped per the payer. So non-groupable codes and groupable codes are going to be paid differently. So jump down to the last paragraph here. Basically, if the non-groupable code is billed with a code that falls in a group, it's going to trump to that case rate of $1,300. So this is just so important to know how that claim is going to adjudicate.
So it doesn't matter if you have 5 procedure codes. Mm-hmm. If the primary procedure is ungrouped, it would pay at this $1,300 flat rate. Yep. That is an expensive section of your contract.
Yeah, and then if you decide to bill non-group codes with those group primary codes, they'll also not pay for those additional codes you use that were not grouped. So.
Okay, Scott. So I know that when you're discussing rates with carriers, you have to be armed with data.
They want to know what you can do for them. Exactly.
Yeah, and this is an example of what you need to do. You need to show them the cases that you bring in and how much you would save them. You need to do your homework before you even pick up the phone. And there is a lot here. But before you get here, you have to evaluate your Chargemaster against your allowed amount and looking at your total cases. So.
Yeah, there's also so many other variables associated with getting better rates.
But that's one. You have to arm yourself with data, and that's the one we see folks miss out on. All right, so as far as opportunities are concerned, I promise you, if you do a proper evaluation of your Chargemaster and educate your coding and billing staff on how it works, that's step one. That's going to improve your revenue. Number two, taking some of the inside tricks of the trade and going back to your carriers when you're armed and prepared, you will have success. And understanding that that contract applies to the entire revenue cycle. It's not good enough to get the rates and then put it in a drawer. You actually have to look at it, read it, and monitor it. And then if there are any changes to your situation, you're adding specialties, you're losing specialties, you may want to revisit these contracts again. Also, we recommend professional review of managed care contracts. We do not do that as a service for the community. We would recommend that you find a company that understands how to do this. It is a large task. We gave you some pointers, so if you are experienced in this and you do understand the contracting part and the revenue cycle part, then you should be just fine. But for those of you that are new to the surgery center industry or you don't do this, then I would recommend having a professional review your contracts for you and help you with that. And we're going to open it up for questions. I believe we finished right on time, Carrie.
Thank you, Lisa and Scott, for a very informative and enjoyable presentation. As Lisa mentioned, we will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and we'll follow up on questions they do not have the opportunity to address. So our first question here from the audience, what type of payers are exempt from HIPAA?
Okay, workers' comp, state Medicaid, and the small little carriers, Indian reservations. So all of your major large payers are going to have to follow HIPAA, but workers' comp is exempt. Now, why is that important? Because if you're exempt from HIPAA, you can require homegrown CPT codes to be used. You don't have to follow ICD-10. You don't even have to follow ICD-9. You can have your own way of requiring facilities to bill. Medi-Cal has, that's the state Medicaid out in California, they go Ohio, follow homegrown codes, and if you bill with a regular CPT code, you're going to be denied. The carrier that I used to work for, before HIPAA, we had our own homegrown codes for a variety of reasons. Mostly, that's how they were put in the system, and we didn't have time to change it. And it's expensive to change it. So for those smaller organizations, they're not required to spend the necessary money to get up to speed with the rest of the world. But as you're billing for these, you have to understand that some of these that are exempt could have their own requirements, and they're different from everyone else, and it's okay.
Great, thank you. Next question we have. We in Virginia were advised not to have more than one fee schedule for legal reasons. Are you saying it's okay to have more than one fee schedule? This audience member says that they have one fee schedule for commercial products and one for workers' comp.
I highly recommend one fee schedule across the board. Now, there's one caveat. If you have contracts that prevent you from getting an increase in your Chargemaster, then you can call the carrier and ask, the one that is limiting you from increasing, and ask if there is any way you can increase your Chargemaster across the board and keep those that internal Chargemaster that they have on file. And many carriers will work with you and do that, but you still have your one Chargemaster. It is the carrier adjusting those charges on their end. But I would always 100% recommend one fee schedule across the board. The only variable would be your implant charges, and those would not be hard-coded in your system.
Great, thank you. Next question we have here. What are the sites you mentioned to look up charges to use as a guide for your Chargemaster? Fairhealth.org, which pretty much took the place of Ingenix. We had the fall of Ingenix, and
And then Fair Health sort of filled that gap. And then your state may have specific, if your state collects ASC data, and most of them do. Florida, for example, has a really good one. Texas has a good one. You can go in and look and see what other surgery centers are charging for particular cases and CPT codes.
Just to point out too, Fair Health does have a free website you can go to, .org. They also do sell private charge data, so there's two different versions of Fair Health. The free website is not as clear. The data that they use is not just strictly from ASCs, and even the ASC data that they sell, we've been finding issues with that, not really meeting requirements.
But it's a good guideline.
It's a good guideline.
I mean, we don't have a whole lot. And using Medicare, we've always done that, but I'm not so certain it's the best across the board.
Great. Thank you. Now, just as a reminder to our audience members, you can submit questions by typing them into your control panel in the space labeled Enter a Question for Staff and pressing Send. We have another question coming in here. An audience member is asking our presenters to repeat names of sources of charge and payment examples other than Medicare.
Charges and payments examples other than Medicare. I'm not sure I understand it. Do you understand the question? Charges and payments. They probably mean, I think it's similar to the last question, fairhealth.org. You can go on and that's not Medicare. It is, it's regionally collected data, and you can put your zip code in. It drills down right to your zip code, Fair Health does. So that's probably what they're talking about, fairhealth.org.
Great, thank you, Lisa. Now, next question we have here. Can I negotiate rates or ask for carve-outs during the initial term of a contract?
Like I said, not typically. If you're adding a specialty, then you have an opportunity to go into dialogue if you make a strong case. Again, carriers are interested, they really are interested in quality care for their members at a reduced cost. Whatever way they can save money, they're going to look for it. So if you can present an opportunity for them to reduce their costs and improve care, if you can make that argument and win that argument, then yes, you can in the initial term. But if you look at your contracts for the first time in 5 years and call up and say, hey, you know, I have a 6-year term and this is killing me, it's worth a shot, but usually you're locked in.
To point out the time length it takes to negotiate existing contract as well, I think misconception is we can get it done in a week or two, but we have many times when these things take up to 2 years to get a good contract in place with the payer.
Well, I think that's a really good point. As you're negotiating contracts or you're hiring someone to do it, you have to allow enough time to do it right. You're not going to pick up the phone and get a rate increase in a couple of weeks, a couple months, or even 6 months. You have to do all of your homework, and you have to work with someone, and you have to listen to their feedback and go back to the drawing board. I mean, that back and forth, as Scott just said, can take a year or two. It is not overnight.
Great, thank you. Next question we have coming in. Do Medicare and Medicaid plans administered by commercial insurers always pay 100% of the applicable state and federal fee schedule?
No, that is a really good question. No, they don't. And I'll give you an example of how they don't. They'll say our rate is 100 or 105% Medicare. Let's say 100% Medicare. Okay, great. I'm not getting any more than I would with Medicare. I'm fine to take this replacement plan. And you're only getting reimbursed now 2 or 3 procedures. Well, you're already now falling below Medicare. Or it is a multiple procedure logic of 150, 25. And now you're falling below Medicare. 2 different ways. It's always in that multiple procedure logic. And so you really have to take a hard look at that. So no, they don't have to pay Medicare rates to you. They don't. and they don't. So.
Wonderful, thank you. Now, next question here. How do I set the charge for CPT codes that don't have a Medicare allowable?
Right. So if you've made the decision to use Medicare to set your Chargemaster, a multiple of Medicare, that's fine. And let's say you have a spine procedure that doesn't have a Medicare crosswalk. Well, that's when you're going to want to use Fair Health. If there's nothing that you can extract from Fair Health or the state, then I recommend costing it out with time, materials, staffing, everything, and applying your margin on top of that and coming up with your charge that way.
Wonderful, thank you. Now, next question here. How long does it take to renegotiate a contract?
Well, like I said before, once you've done your proper homework and you're ready to talk to the carriers, then you start with a dialogue over the phone, but your contract negotiation may involve face-to-face meetings. It should involve surgeons, especially with complex procedures. You're not talking to a physician when you're negotiating a contract. You may not be able to articulate the complexities of what he or she is doing, and in that particular area. And so having the surgeon help you at the end game is critical. And that whole process, just one thing building on another until you get to that point, and you do it by developing a solid relationship, by the way. You certainly don't get it by calling a pair up and saying, you know, you bunch of you-know-whats, I'm going to terminate if you don't work with me. Well, you better check your state laws, because if there is not an any willing provider law, which means if I as a surgery center meet credentialing criteria, I can get in. Once you go out, you may not be able to get back in. And we have a whole lot of stuff going on in the market right now out of network that could dictate exactly how the future of out-of-network billing will be handled. And so we're all watching it very, very carefully right now. So you want to be very careful of that kind of an attitude where you either threaten termination or you get booted out. It has to be a very gentle touch when you're working with carrier, and they require a lot of data before they're going to listen to you. So don't even walk in the room without it, because just simply going in and saying, I want a 20% increase isn't going to get it. So that whole process takes, like we said, a year or two.
Thank you. I want to again thank our presenters for their excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.